Thank you very much, Laura. Excuse me, I've still recovering from a bit of a cold. It's always a pleasure to be here at this conference, and today I'm going to just talk through some of the problems that our patients experience with the tummy, and I'm going to start with this introductory slide just to, right at the beginning, describe the range of symptoms that our patients complain of. And as you can see, right from the top to the bottom, there are symptoms related to the entire gut with nausea, vomiting, heartburn, belching, bloating, indigestion, epigastric pain, fullness, constipation, diarrhea, alternating bowel habits. But some of these symptoms, particularly nausea, heartburn, bloating, and the indigestion type of symptoms, the upper tummy pain, epigastric pain, fullness after meals, these are particularly common in this patient group. And abdominal pain is almost probably the most common symptom that our patients complain of. And similarly, change in bowel habits is a pretty common problem as well. But the question I think we all need to address is why? Why are our patients experiencing so many gastrointestinal symptoms? And to address that question, I think first we need to understand how the gut functions. What is the anatomy? What is the physiology? How does it function? And where do the problems occur within the gastrointestinal tract that lead to the symptoms that our patients are experiencing? So as you can see, the gut is a long tubular structure, starts from the mouth down to the esophagus, our food pipe, which transports the food down into the stomach, which mixes the food with acid and breaks it down into small pieces. The food starts to get digested with various digestive juices and then moves down into the small bowel. The small bowel is where the food is digested, all the nutrients are absorbed, and the waste goes into the colon. And in the colon, the water is absorbed from the waste, and then the hard stool arrives in the rectum for it to be evacuated. So it's a long tubular structure which has different functions in different parts of this tubular structure. Now, within each part of the gut, there are many different subsections. So these are the different layers within the gastrointestinal tract. And as you can see, is there a cursor at all that I could use, or a pointer? Yeah. Okay. So if you actually look at the tubular structure over there, the innermost part of the gut is the mucosa, or the lining of the gut. And within that, there are many different layers. And there is a layer of lymphatic tissue as well, which has quite a lot of the immune cells within it. And beyond the mucosa is the submucosa. And within that, there is a very, very rich plexus of nerves. And beyond that are the muscle layers, the inner circular and the outer longitudinal muscle layer. And between those is perhaps the largest plexus of nerves called the myenteric plexus. Okay? And the number of nerves in the myenteric plexus and the submucous plexus are as many as the nerves there are in the spinal cord. So this is an organ which is very richly innervated by these nerves. And then beyond that is the lining of the serosa, which contains the blood vessels, and these blood vessels come all the way down to the submucosa. So it's a complex structure with many different layers, and problems can occur in different layers of the gut, leading to symptoms that our patients experience. In addition, there is the gut microbiome. So there is a whole organ system within the gut, which is the gut microbiota, these small organisms that are present in our gut, and there are billions of these. There are as many or probably more gut microbiota than the number of cells in our body. And this is an entire ecosystem which communicates with all the different layers that we described, particularly the lining and particularly with the immune system. And these microbiome, they help with the digestion of food and help to regulate the lining of the gut and also regulate the immune system. And then all of this communicates, all the functions that are going on in the gut, they are communicating with the brain through the nervous system, through the hormones, through the immune system. So everything that goes on in the gut is reported to the brain, and then the brain sends modulatory signals back to the gut, and this is described as the brain-gut axis. So as you can see, it's a very complex system, and things can go wrong at different levels of the system to cause the symptoms that our patients experience. So I'm going to try and go through this complexity slowly, and we're going to look at how this system works and where the problems occur. But before we do that, just to describe to you that connective tissue is present within the gut, particularly in the muscle layers. As you can see, this is a cross-section showing the outer longitudinal muscle and the inner circular muscle. And you can see these long connective tissue, darkish red scaffolds that come down the muscle. And then in between the two muscle layers are the nerves, the myenteric plexus. And you can see quite a lot of collagen fibers and elastin fibers around the nerves as well. So it is not surprising that when something goes wrong with the connective tissue, the gut also can malfunction, and that can malfunction because the effect of the connective tissue on the muscles, but also on the nerves as well. So gut problems in our patients can occur because of problems that can occur in the lining of the gut, in the immune system of the gut, in the nerves, the muscles, the blood vessels. So we're going to explore what these problems are and how they can lead to the development of symptoms. And we're going to look at the lining of the gut and the immune system together because they're very closely interrelated, as you will see in the subsequent slides. So what you're looking at here is the lining of the gut and its surroundings. So the top layer are the cells. So you can see 4 cells, and the little serrations at the top are the part of the cell that is opening up into the lumen or the cavity of the gut. And these cells are very tightly bound together by proteins that are the important ones are the tight junction proteins that literally zip up the cells together so that there are no gaps that are there between the cells. Because the gut has a lot of different allergens, other antigens, bacteria, etc., within the lumen of the gut, these tight junctions prevent any of those getting through. If anything does get through, then there is a very rich immune system underlying the gut. That's the second major protective layer. And you can see that there are many, many different types of immune cells that are there to protect us from anything that actually gets through. Let's see. The top one. No. Doesn't project. Doesn't matter. It's okay. Yeah, doesn't matter. So, and within this immune system, there are these, in the middle you can see that big blob, which is the mast cell, okay? So mast cell is like the bouncer at the gate, the first responder. So anything that comes through, the mast cell will react to that and release a number of different types of chemicals. Histamine is the most commonly known one, but there are many other different chemicals that are and neurotransmitters that are released. And what you can see is that these chemicals that are being released are having an influence on all the different structures that are present within the gut. They are having an effect on the blood vessels, on the muscles, on the nerves, and so on. So as you can see, if this immune system gets activated, particularly the mast cell gets activated, it has very widespread affects, and it can affect all the different structures that are within the gut. And a consequence of any inflammation or injury that occurs to the gut can be that it makes the gut leaky. And what sort of inflammation and injury? An infection can do that. A gastroenteritis can do that. COVID can do that. Various other viruses can do that. And drugs can do that. There are various drugs, particularly non-steroidal anti-inflammatory drugs can do that. And many different conditions which are more autoimmune conditions, which increase immune sensitivity within the gut, they can all alter the permeability, or these tight junctions between the cells get disrupted and gaps appear between the cells. As you can see, there are gaps now that have appeared, and the gut has become more leaky. So now the particles that are the allergens that are present within the lining of the gut, they can get through, drug particles can get through, unhealthy bacteria can get through, and then the immune system underneath those bounces really react and respond. And when that happens, a lot of chemicals are released, and that is often the basis of the food allergies and intolerances and the immune system abnormalities, and eventually leading on to autoimmunity. And then all of that is happening here, we know communicates up with the brain through the blood, through the circulation, through the nerves, through the immune system directly, and they breach the blood-brain barrier, and they affect the brain as well, and you can get more central symptoms as well. And the mast cell plays quite a central role in the early response that occurs in the gut in response to these allergens getting through. And we've all heard of these mast cell related symptoms or mast cell activation syndrome or disorder. And I have to say that the evidence for that affecting the gut in EDS patients is not quite there yet. And that's not because it does not occur, it's because the studies that are needed to demonstrate it have not yet been performed. But nevertheless, mast cell-related problems are recognized in the gut, in irritable bowel syndrome, in dyspepsia, and so on, and there is no reason to believe why they would not occur in the same way. And we've seen that after COVID as well, that they could not occur in the same way in our patients. But when mast cell activation disorder occurs, or mast cell activation syndrome occurs, where the syndrome would mean that there are multisystemic effects, you can see that almost any part of the body can be affected. But particularly in the gastrointestinal tract, mast cells, the mediators released, can cause diarrhea, nausea, vomiting, abdominal pain, bloating, gastroesophageal reflux disease, and so on. So you can see how this system could work just through the breach of the lining of the gut becoming more leaky and more permeable. We move on to the effect of the what would happen if the nerves in the gut become more sensitive, because that can lead to the generation of abdominal pain. This is an interesting study which was done to look at abdominal pain in patients with hEDS HSD versus the population. This pie chart on the left-hand side is the population controls. On the right side, you see patients with HSD and hEDS. And it's a complex slide, but if you just focus on the top part on the left side, which is 14% of the patients complain of pain almost on a weekly basis, daily basis, every day, or multiple times of the day in the population. Whereas in hEDS patients and HSD patients, 75% of them complain of pain, abdominal pain, on a weekly, daily, and multiple times a day basis. So abdominal pain, the frequency of abdominal pain is very common in our patients. So why is that the case? So pain can occur from many different reasons, but the basic physiology of pain is that when peripheral nerves are injured or inflamed, just as in the hand, you drop a bit of hot oil or you hurt your hand, pain nerves are activated in the peripheral structure like the hand, and those pain nerves carry signals up to the level of the spinal cord, And from the spinal cord, they ascend upwards to the pain centers of the brain. And when those pain centers are activated, you experience pain, and you also identify which part of the body the pain is actually coming from. In addition to these ascending pathways going up to the brain, in blue, you can see the descending pathways coming from the brain pain centers down to the level of the spinal cord. And the purpose of these descending pathways is to inhibit pain signaling at the level of the spinal cord. So the amount of pain you feel is the balance between the intensity of the signal going up and the inhibition of that signal from the top down from the brain to the level of the spinal cord. And if that inhibition is reduced, as it does happen at times of stress and so on, then the same pain signal can feel more intense because now it's not being gated or inhibited by these descending pathways. But when there is an intense injury to the peripheral nerves, the signaling that goes up to the level of the spinal cord is also very intense. And that leads to more permanent sensitivity of the peripheral nerves, described as peripheral sensitization, and more permanent sensitivity at the level of the spinal cord, leading to central sensitization. The importance of this is that in this situation, once the nerves are sensitized, they retain the memory of that sensitivity so that even though the peripheral injury may heal, if you burned yourself, the burn may actually heal, but the nerves will remain sensitive. And this happens in another example is shingles. People get these sores on on different parts of the body when they have the herpes zoster infection. That heals, but the area can remain sensitized for a long time because the peripheral nerves have become sensitized and the central nerves have become sensitized and they've retained the memory. And even though the inflammation goes away, the nerves remain sensitive. And exactly the same thing can happen in the gut as well. The gut can get inflamed and injured, just like your peripheral limbs can get inflamed and injured, and you can get sensitization of the nerves and going from the gut to the spinal cord. And that leads to this peripheral and central sensitization, leading to chronic pain. And there is evidence to suggest that our HEDS and HSD patients are more prone to develop this peripheral and central sensitization, and therefore they develop more chronic pain. Moving on to the muscles, which is, if there is a problem with the muscles, then there will be a problem with the movements, and it was described as mechanical problems, slow movements, which Dr. Pimentel is going to talk to in more detail. But I'll just mention some of the key issues here. So these mechanical problems can occur anywhere in the gut. They can occur in your esophagus, or which can cause difficulty with swallowing. People feel as if food is sticking in the esophagus. And you can get problems at the level of the gastroesophageal junction, which is the junction between the stomach and the esophagus, where there is a valve, which can be weak, and the whole structure around the lower end of the esophagus can be weak, so that provokes more acid reflux. If there can be a sluggishness in the stomach, which can lead to delayed gastric emptying or gastroparesis, which can cause fullness and nausea and vomiting. And you can actually then get problems in the small bowel with the motility being slow. And if that's the case, that can lead to unhealthy bacteria growing because of stagnation, called small intestinal bacterial overgrowth. And if there are problems in the movement of the large bowel, that can cause constipation. Or if the movements are actually too rapid, that can cause diarrhea. And finally, there can be problems of evacuation, so that the rectum is not able to evacuate adequately. Now, in terms of constipation, you can experience constipation because the transit is slow. Things are slow in getting from A to B. The X-ray that you see is an X-ray of a transit study where radiopaque markers are given to the patients in different shapes, and you see where those markers are after 5 days when you take an X-ray. And most of these markers should have been expelled by then, but here you see that most of the markers are still present in the gut, mostly on the left side, but scattered around a little bit as well. So this patient has slow transit, and we see that in our patients with EDS as well. We also see problems with anatomical problems in the rectum. At the back, you can see that the rectum is supposed to be in normal anatomy, just a slightly curved structure, and when the stool arrives there, it is expelled down towards the anal region. But when you strain, in some people, a pouch can form in the rectum called a rectocele, which can trap the stool, and that can then feel as if, even if you've emptied your bowel, you feel as if something is left behind, something described as incomplete evacuation, and that can be quite distressing for the patients. In other cases, despite a lot of effort, a lot of straining, nothing much happens, and that is when you develop a little prolapse of the bowel, so that when you strain the rectum, instead of squeezing the stool out, it sort of flops down on itself, collapses, and there is an internal prolapse of the rectum called an intersusception, and that can trap the stool and it can't get down properly. Now, so all of these can lead to constipation, and understanding whether it's a transit problem or an evacuatory problem due to an anatomical issue is important, because no matter how much you stimulate the gut, if you have an evacuatory problem, you'll still have difficulty in getting rid of the stool. Moving on to diarrhea, there are different reasons why our patients experience diarrhea. One of the common ones that I see is due to bacterial overgrowth. And that is because of the stagnation, because of the slow motility in the gut. Everything stagnates. And when you know that things stagnate, you can get quite a lot of bacteria developing there, because you've got food, fluid, stool all mixed in there. And there is a rich supply of bacteria already in the bowel, and mostly in the large bowel, but that translocates and moves into the small bowel. And you can get bacterial overgrowth in the small bowel, which then starts to ferment your food, and people can get a lot of distension, bloating, cramping, abdominal pain, and diarrhea, which is often fatty, oily looking diarrhea, because you get malabsorption of fat alongside with that. Another cause of diarrhea is the overflow diarrhea that we see, that some patients are so constipated that the stool is so hard that the only way it can get out is by breaking on the edges, and liquid stool just literally pours down into the rectum. And often this is associated with urgency. Patients have to rush to the toilet and can sometimes have accidents, and you get very liquidy diarrhea. It may happen once or twice, then go away, and you go back to your constipation phase, and then after a few days, this can recur. So the treatment of that is to actually get rid of this hard constipated stool. Sometimes we have to use bowel prep that you use for colonoscopy, etc., to get rid of that. And the third type of diarrhea that we see is related to the mast cell or immune-mediated problem in the gut, that your gut immune system is very reactive. And when you eat and drink, in this case, the diarrhea usually occurs pretty quickly after eating, but is also associated with other symptoms of feeling hot and flushed and sweaty, palpitations, itching, and so on as well. Now, moving on to the problems that can occur in the blood vessels, and particularly I'm going to talk about POTS and vascular entrapment syndromes. So this is a very nice study that showed that patients with functional gastrointestinal problems like irritable bowel syndrome, functional dyspepsia, etc., when they looked at symptoms that these patients present with in those who had POTS and those who did not have POTS, all of the symptoms were more common in those who had POTS. So we're looking at the POTS patients in red and the POTS negative patients in blue, and you can see all the bars for all the symptoms are much greater in the POTS patients than those who do not have POTS. In our clinical experience as well, and what the study showed as well, that the upper tummy symptoms of nausea, vomiting, pain in the upper part of the abdomen called epigastrium, fullness, and feeling full very quickly after meals called early satiety, all of those are much more common in our patients who have POTS. And this is an observation that has been in other studies as well. And the question is why? Why is that the case? Now, a subgroup of patients with POTS have what is described as a neurological component or a nerve-mediated component, which means that their autonomic nervous system nerves, particularly the sympathetic nerves, they are more active. As you know, the autonomic nervous system has a sympathetic part and the parasympathetic part. The sympathetic part from the heart point of view is your fight and flight nervous system, makes your heart beat faster. So you need to run away because you're in danger, or you need to fight. Your heart needs to pump blood into your limbs. It has to beat faster. But at the same time, when you're in fight and flight, you don't want your gut to be very active. You don't want to be feeling hungry or wanting to go to the loo. So your gut gets inhibited at the same time. And a subgroup of POTS have overactivity of the sympathetic nervous system. So while the heart rate is going quite high, the upper part of the gut particularly gets inhibited, and you will get delayed gastric emptying. The parasympathetic nervous system has the opposite effect. It decreases heart rate, and it increases motility. And there is evidence in POTS patients and in hypermobile patients in general that the parasympathetic nervous system function is diminished. So the vagus nerve is not as active as it should be. So therefore, the sympathetic nervous system is almost unopposed, and you get more activity of the sympathetic nervous system, causing the elevation in heart rate and a reduction in the movements of the gut. And in studies that have been done in EDS patient and those with POTS have shown that there is a subgroup where the stomach emptying is quite delayed, there's a subgroup where the emptying is normal, and there's a subgroup where the emptying is accelerated. So they have more rapid gastric emptying as well. The ones that have the delayed gastric emptying are likely, in some cases, to be mediated, if they have overlapping POTS, to be mediated by the effect of the sympathetic nervous system. Now, a lot of you would have heard of postprandial or after meals, patients get a worsening of their POTS symptoms. And the reason for that is likely to be that the gut has a very rich blood supply. As you can see, there are many different major blood vessels that supply the gut. And when we eat, there is an increase in blood flow to help to digest the food in the blood vessels of the tummy cavity. So if you're running on a low blood pressure and your intravascular volume is generally low and you lose blood to the tummy cavity, then that can cause symptoms in the same way as when you stand up, you get symptoms. So people can get dizzy because of the loss of, and there is some evidence to suggest that POTS patients may retain the increased, they may have a greater capacity in the blood vessels, and they may retain the blood there for longer than it normally occurs, leading to more prolonged symptoms. And after eating, because of this change in circulating volume, people can feel lightheaded, fatigue, drowsiness, even to the extent of sometimes even fainting, but nausea, bloating can also occur. Then you may have heard of dumping syndrome. In this situation, the emptying is actually more rapid. So food is actually getting through the stomach much more quickly. And there are two types of dumping, early and late dumping. So in early dumping, you get symptoms very quickly after you've eaten, within 30 minutes of fullness, of feeling weak, dizzy, excessive sweating, and you can get palpitations, cramping, and so on. And the way to manage that is by not drinking fluid with meals, because fluid pushes the food through much more quicker and reduce the carbohydrates. And the cause of that is that when food gets into the small bowel very quickly, there is release of a lot of neurotransmitters and some hormones as well that lead to a fluid shift. The fluid moves from the vascular cavity into the lining of the gut, and that leads to this development of these symptoms because the blood pressure changes can occur, but at the same time, there's a lot of fluid in the gut, and that also causes these symptoms. You can also get late dumping, which occurs 90 minutes to 3 hours after eating, and that is due to the sudden rise in blood sugar because of the rapid transport of high carbohydrate content into the bloodstream. The sugar level rises, and there is an excessive secretion of insulin, that causes a sudden inhibition of blood glucose, reduction in blood glucose causing hypoglycemia, and you get low blood sugar type of symptoms of feeling very fatigued, sweaty, clammy, and so on. And just want to briefly mention the vascular entrapment syndromes, which we have no evidence to say that these are increased in patients with EDS, but certainly we have seen quite a few EDS patients now with these vascular entrapment syndromes. You can get the superior mesenteric artery syndrome, where the superior mesenteric artery collapses and the angle between that and the aorta becomes narrow, and it traps the duodenum as it passes through that angle, and that can cause obstructive symptoms in the duodenum, which can cause nausea, vomiting, but also quite a lot of abdominal pain. You can get the nutcracker syndrome, where the renal vein is trapped between the superior mesenteric artery and the aorta. The May-Thurner syndrome, where the left iliac vein is trapped by the right iliac artery. And then there is the median arcuate ligament syndrome, with the median arcuate ligament, which should be above the celiac artery, is much lower down, and it actually causes a compression of the celiac artery. And these patients can tend to get a lot of post-meal pain. We don't know what the incidence is in EDS patients, but in younger patients, particularly with a lot of post-meal pain, it is worth exploring that possibility. Now, how does it all come together? You've got EDS, we've got POTS, mast cell, tummy problems. How do we bring it all together? Why is all of this happening in our patients? And I think what I'd like to say is that we have a very integrated system. When the body is under stress, be it psychological stress or physical stress, when you have an infection, there are these three stress response systems that are activated. There is the autonomic nervous system, which is our stress response system. The hypothalamic pituitary axis is the endocrine system, which releases cortisol. That is activated, and the immune system are activated. And they have reciprocal effects, because the cortisol and the autonomic nerves have an effect on the immune system. The cytokines, or the inflammatory proteins released by the immune system, have an effect on these nerves, but they also go up via the bloodstream up to the brain and have an effect on the hypothalamic pituitary axis and so on. So there is a very intricate action, and if anything goes wrong in one part, the other parts also get affected. And this is nicely described in this figure as to what is the effect of stress, be it physical or psychological, on the gut. So you get activation of all of these stress response systems, the hypothalamic pituitary axis, the autonomic nervous system, the immune system, and that then leads to downstream effects within the gastrointestinal tract. It disturbs the immune system there, it can cause mast cell activation, the gut microbiome can get activated, inflammatory proteins can release, and that can change function of the gut. There can be problems in the neuromuscular function, sensitivity of the gut, barrier function of the gut can be affected. It can make it a lot more leaky. So coming to management, the end, and just to say that it is important for us to recognize as healthcare professionals that our patients are experiencing these multiple problems, and there is a reason for that, and for us to actually transmit to our patients to let them know that we understand and there is an explanation for these multiple symptoms that they are experiencing. I think it is important, and we keep saying that we need a multidisciplinary approach with dietitians, pain management, psychologists, colleagues who understand these different problems, but often practically it's difficult to achieve. And that needs to be addressed in the future, and I know that the society is doing some wonderful work on creating these centers of excellence, which shall hopefully overcome some of these problems. It is important to rule out other causes of symptoms in our patients, and there is some evidence to suggest that inflammatory bowel disease, celiac disease, autoimmune connective tissue disorders can also occur in our EDS patients. And I won't go into the gut investigations because Dr. Pimentel, I think, is going to cover those, but there are lots of tests that can be done to understand the function of the gut. We know that we can do x-rays and scans and endoscopies to look at the structure, but there are lots of tests to understand the function of the gut that can be performed as well to try and figure out what the problem is and how best to manage that. There'll be more discussion about diet and lifestyle later on today. It's just to say that basic lifestyle modification like increases in fluid intake will not just help your POTS symptoms, but will also help with your constipation as well. And improvement in salt intake, etc. Improvement in POTS symptoms often leads to an improvement in upper tummy symptoms as well, particularly nausea first thing in the morning will improve. Food is a major trigger for gut symptoms in many of our patients, but we still lack good evidence that any particular diet is really effective. There is some evidence for the low FODMAP diet, but that's very preliminary. And we know a lot of our patients benefit from low reduction in carbohydrates and from particularly fermentable carbohydrates. And patients with irritable bowel syndrome benefit from that, and we know that 50% of our patients with EDS also have irritable bowel syndrome. So there is no reason to believe that these diets will not work, but they've not been specifically tested properly in our EDS population. And the same is the case with the low histamine diet. Many patients benefit from it. But the important thing is that proper dietary advice needs to be taken. Healthcare professionals, dietitians need to be involved in the development of a dietary plan for our patients. And taking a good dietary history, food diary, keeping a food diary to identify specific triggers and avoid unnecessary dietary restrictions is particularly important. Management of constipation, dietary changes, just improvement in your fiber intake, both soluble and insoluble fiber intake can help. But sometimes we do need laxatives like stool softeners, like Movicol, which is a pegylated solution, but sometimes stimulatory laxatives such as Senacot, Dulcolax are required. And Resolor, which is a prokinetic medicine which helps to stimulate the nerves in the gut to produce stronger muscle contractions, is particularly helpful in our patients with slow transit constipation, and is usually well tolerated. And linaclotide or Linzess is another medicine which is a secretagogue which helps to secrete more fluid in the small bowel and also improves motility, can be used in more moderate to severe patients with constipation, in those with rectal evacuatory dysfunction. Suppositories like glycerine or bisacodyl suppositories can help. And some of our patients need to go on to have pelvic floor physiotherapy called biofeedback. Sometimes we need to clear the bowel out to stop the overflow diarrhea. And in those with anatomical problems, sometimes surgery is required. I'm not going to dwell on mast cell activation treatment because I'm sure other colleagues during the course of this conference will be talking about that. But dietary management, avoiding high histamine triggers, and it's not to say go on a low histamine diet, but identify your high histamine or any other food-related triggers that might help. And type 1 antihistamines like cetirizine, fexofenadine, type 2 antihistamine, famotidine, leukotriene inhibitors like montelukast, and mast cell stabilizers like ketotifen, sodium chromoglycate, all have a role within this. And just to say a quick word about enteral and parenteral nutrition, feeding through the gut with a tube or intravenously, it has to be approached with caution because there is a high failure rate, infections are common, pain can still occur if you're being still fed in the gut, and consideration should be given to other conditions like POTS and mast cell activation disorder, which can be perpetuating the symptoms, and treatment of that can sometimes lead to a significant improvement in nutrition. And of course, psychological issues like anxiety, depression, eating disorders, which will be discussed later on today, all need to be discussed and considered. And pharmacological therapy for POTS particularly can be helpful. There is certainly our experience suggests that improvement in POTS leads to improvement in upper tummy symptoms and fludrocortisone and midodrine. But pyridostigmine, which is an anti-acetylcholinesterase inhibitor, which increases the nerves, the function of the nerves in the gut and increases stomach emptying, but at the same time, it reduces heart rate. So it's a very effective treatment in patients with POTS, and we found it very effective in those with COVID-induced POTS and gastrointestinal problems. And this is something that needs to be tested in the future, and hormonal treatment like octreotide, etc., psychological support. And just remains for me to thank so many different people who've been so helpful in the development of all the work that I've just described. Thank you very much.